Good afternoon and welcome to our congressional briefing and national webinar on the report, Ready or Not 2023, Protecting the Public's Health from Diseases, Disasters, and Bioterrorism, hosted by Trust for America's Health, or TFAH for short. My name is Tim Hughes, the External Relations and Outreach Manager at TFAH. We would like to thank our speakers and audience for being with us today. Next slide, please. We're working to bring up our live captioning, and we'll have that going as soon as possible. For captions, click on More at the bottom right of your screen with the 3 dots. Next, click on Close Captions. As a reminder, we'll work to have that up as soon as possible here. Next slide, please. We encourage you all to share your thoughts and questions about today's presentation by typing them into the Q&A box. We'll try to answer as many as we can as time permits. To open the Q&A box, click the Q&A icon and at the bottom of your screen. From there, select Enter when you are ready to submit your question. Next slide. And now it is my pleasure to introduce the moderator of this event, Dr. J. Nadine Gracia. Dr. Gracia is the President and CEO of Trust for America's Health. She is a national health equity leader with extensive leadership and management experience in the federal government, the nonprofit sector, academia, and professional associations. As President and CEO, she leads TFAH's work to advance sound public policy, address the social determinants of health, advance health equity, and make health promotion and disease prevention a national priority. Before joining TFAH, Dr. Gracia was the Deputy Assistant Secretary for Minority Health and Director of the HHS Office of Minority Health during the Obama administration. Welcome, Dr. Gracia.
Thank you, Tim, and thanks to everyone for joining us today for this briefing and important discussion. As Tim noted, my name is Nadine Gracia, and I'm the President and CEO of Trust for America's Health. I'd like to first welcome you all and thank our esteemed panelists for participating in this event. We are so honored to have your expertise and experience that's going to really help inform this discussion. Our agenda for today is on this slide, and after our panelists deliver their presentations, we will have time for discussion and questions from the audience. Our goal for today's briefing is that our audience leaves with a better understanding of the policies and programs that impact our nation's preparedness and response for emergencies and disasters of all kinds, from infectious disease outbreaks and pandemics to extreme weather and man-made disasters. Next slide, please. Now, before I introduce our panel, I'd like to start with a brief overview of Trust for America's Health's 2023 Ready or Not report. A copy of the full report, including state-specific information, is available on our website at tfah.org, that's tfah.org, and we'll include a link to the report in the chat. This is the 20th edition of the Ready or Not report, which includes 10 key indicators of preparedness across a range of topics. In this year's report, drawing on lessons learned from the COVID-19 pandemic and past public health emergencies, we also included a special feature on the intersection between health equity and emergency preparedness and the challenges in measuring equitable preparedness and response. And lastly, we include recommendations for policymakers to improve the nation's health security. Next slide. The Ready or Not report tiers states and the District of Columbia into 3 performance levels for health preparedness: high, middle, and low. And this year's report placed 19 states and Washington, D.C. in the high performance tier, 16 states in the middle performance tier, and 15 states in the low performance tier. As I mentioned, we looked at 10 indicators, which are selected largely from the National Health Security Preparedness Index and in consultation with experts. Now, it's important to note that this isn't intended to be a comprehensive assessment of preparedness, but really to give states actionable data and steps that they can take to help improve their readiness. And even states in the high performance tier have opportunities for continued improvement. This is also not an evaluation of any single department or entity, because as you're going to hear, preparedness really requires action by multiple government agencies, by lawmakers and other decision and policymakers, by the healthcare system and providers, and the public. Next slide, please. In this year's report, our key findings, we found some areas of progress over the past few years. Some of those include an increase in the number of states that are participating in the Nurse Licensure Compact, which allows nurses to practice across state lines. And nearly every state public health laboratory had a plan to be able to surge their testing capacity, in particular during times of emergency. Most states are accredited in either public health or emergency management, or both, and most residents have access to safe drinking water. And we've also seen some major investments in the past few years in developing the public health infrastructure and workforce, which certainly could have significant benefits to a system that has been chronically underfunded. Next slide, please. However, we certainly also saw important challenges. Only about half of the US population is served by a comprehensive public health system that provides essential services to everyone. And we saw a decrease in seasonal flu vaccination rates. Too few workers have paid time off to be able to stay home when ill and recover from an illness, or to be able to take care of a sick family member. And not enough hospitals are achieving top quality patient safety grades. So together, these factors really make it more challenging to be able to protect every community during an emergency. Now, again, for a full description of the state-by-state data, along with the recommendations that accompany that in this report, I encourage you to explore the full report on our website. Next slide, please. In this year's report, we also included a special feature on the intersection between community resilience, emergency preparedness, and health equity. It's been widely discussed how the COVID-19 pandemic has exposed and exacerbated health disparities. And this is true as well of past public health emergencies. So here we discuss the interdependence between health equity and risk during an emergency. We also discuss the complexity of measuring health equity and its impact on emergency preparedness, but we also underscore how vital it is to address health disparities in planning and response. We believe strongly that would help emergency planners, policymakers, and others in the future, and in meaningful partnership with community to better understand the disparities and structural inequities that exist in their communities, to be able to promote community preparedness, resilience, and recovery. Next slide, please. Finally, our report includes recommendations for policymakers at all levels, as well as for public health officials, the healthcare system, and other stakeholders. 2023 is an important year in terms of public health preparedness. This year, we are urging Congress to reauthorize the Pandemic and All Hazards Preparedness Act, also known as PAPA, which is a foundational piece of legislation that authorizes some of the public health and medical preparedness capabilities that you're going to hear about from our speakers. The current authorization expires on September 30th of this year. We're calling on Congress to enable more effective responses through better public health data capabilities, which are critical for quickly detecting and containing health threats. We want to make it easier for health agencies, including at the federal level, to be able to hire people during an emergency. We support a budget designation that would allow federal funding of health defense programs without the same budget restrictions as many other programs. And we also know that advisory committees that exist on children, individuals with disabilities, and older adults are going to be sunsetting this year. And so we are also advocating that those committees, advisory committees, should be extended. Next slide. In addition to PAPA, we are urging lawmakers at all levels to invest in the public health system and infrastructure that are so integral to our nation's preparedness. Researchers estimate that an additional 80,000 full-time equivalent state and local public health workers are needed to provide a minimum set of basic public health services. We're calling for increased funding in public health emergency preparedness grants and hospital preparedness funding that goes out to every state to be able to prepare for a range of health threats. And we want to ensure that everyone has access to recommended vaccines without cost sharing. We're urging Congress to pass job protected paid leave. And until that time, that states and localities really having the opportunity that they should ensure that their residents have those types of protections. We support the development and distribution of medical countermeasures, which are the drugs and vaccines and devices that are used to prevent and treat times of outbreaks. And finally, we're calling for addressing non-medical but health-related factors, such as nutrition, and transportation and housing that impact a community's resilience and recovery in the face of disasters. Next slide, please. So here's the link that we're also including in the chat to our Ready or Not report. You can also access and see more information about TIFA's other policy priorities, and we encourage you please to review those, the report and other information that we have available on our website, and not hesitate to reach out to our organization as you're also engaged in this work. Next slide, please. And we're going to save questions for the end, but just a reminder to please submit your questions in the Q&A box, not in the chat, and we'll get to as many of those questions as possible after our presentations. So with the background on the 2023 Ready or Not report, I'm now really pleased to welcome our esteemed panel, and I'll introduce each of them and then turn it to our first speaker. Our first panelist is Dr. Mashika Roberts, who is the Columbus, Ohio Health Commissioner, where she leads a team of more than 500 public health professionals. Dr. Roberts has a prolific 20-year public health background at the local, state, and national levels. Prior to her appointment as health commissioner in 2017, she was the medical director and assistant health commissioner at Columbus Public Health. Dr. Roberts is also the immediate past chair of the Big Cities Health Coalition. Our next speaker is Dr. Joelle Simpson, who is the Chief of Emergency Medicine and Medical Director for Emergency Preparedness at Children's National Hospital in Washington, D.C., and an Associate Professor of Pediatrics and Emergency Medicine at George Washington University School of Medicine and Health Sciences. She's a member of the National Biodefense Science Board, providing guidance to the HHS Assistant Secretary for Preparedness and Response on scientific, technical, and other matters related to public health emergency preparedness and response. In 2022, Dr. Simpson was awarded a $30 million grant from the Health Resources and Services Administration to build a pediatric pandemic network. She also serves on the American Academy of Pediatrics Board of Directors. Our third speaker is Mr. Andrew Pickett, who is the Director of the Bureau of Emergency Preparedness and Response with the Pennsylvania Department of Health, having been appointed to the position in 2015. In this role, he manages public health and medical preparedness and response efforts across the Commonwealth of Pennsylvania. He currently serves as the chair of the Association of State and Territorial Health Officials, Director of Public Health Preparedness Peer Group, and has previously served on several ASTO and other public health preparedness committees and work groups. So as you can see, we have a tremendous panel of experts joining us today, really to be able to tackle and address some of these critical issues as it relates to public health preparedness. So it is now my honor to welcome Dr. Mashika Roberts from Columbus Public Health as our first speaker. Welcome, Dr. Roberts. I will turn it over to you.
Well, thank you, Dr. Gracia. Thank you so much for having me on this panel this afternoon. It's my pleasure to be here and share my perspective, as well as many of the perspectives of other big city health departments across the country. As we all know, the last few years have taught us many things, but what really rises to the top is what's most important or challenging. This has been a very challenging time to be in public health, but it's been an enjoyable time at the same time. COVID-19 really put the spotlight on public health. Many individuals had no idea what public health did and what public health work entailed until the pandemic hit. And the critical work we do every single day, even when there's not a pandemic, with diverse communities all across this country. And yet, in spite of this, in spite of the spotlight, in spite of everything we've learned, we are still faced with public health funding challenges, which impede the great work that we want to do and we must do to protect our communities. I'll take the next slide. So if we all go back to September of 2001, September 11th of 2001, we know that after those attacks that the federal government gave public health a large amount of preparedness funding. And that funding was sustained for some years. But as the terrorism fears waned, Congress' attention shifted, and then the funds have been reduced gradually every single year since then. Today, public health funding is not sustained, nor is it predictable. it's leading to this boom or bust funding cycle. This funding leaves some health departments unable to maintain a basic level of preparedness and response. And we saw some of that firsthand when the pandemic happened, that some health departments just didn't have the infrastructure in place to respond appropriately. Only a handful of large city health departments receive resources directly from the federal government. So most, like mine here in Columbus, Ohio, must wait on dollars as well as supplies like vaccines to filter down through state governments. When they're faced with public health emergencies, this extra time really impedes our ability to help those who need our help the most. It slows us down, and thus it can really negatively impact our residents. Time is critical when we have an emergency. And so having those resources on hand already and not have to wait for them to be passed through creates a lot of extra time and extra frustration. Many cities have plans in place for emergencies like COVID-19, but the dollars needed to make those plans work lagged far behind as well. So it's not only money, but it's the resources. Our federal government in the past, and to my knowledge from the long-term past, has had this attitude that they're going to give very time-limited and disease-specific resources, usually when an outbreak occurs. And the federal government distributes most of its dollars on individual diseases rather than core capabilities. This has meant that health departments still have available dollars from COVID-19 that we haven't used, and if we aren't able to use in a timely fashion, might have to be sent back. This obviously will affect our ability to respond to the next outbreak, because then we'll have to wait on additional funding for that. This can threaten lives and threaten the public health safety and health of our community. I'll go ahead and take the next slide. The best example of this funding limitations in practice is the mpox outbreak that happened, at least here in my community, in the summer of 2022. Local health departments received federal dollars from mpox, but it was after we responded. We were in the process of still responding to COVID-19, still providing vaccines for that, still tracking cases, and then mpox appeared. And that meant we had to track individuals with mpox as well as close contacts. And then shortly thereafter, we had a vaccine that we could give to individuals who were at risk for mpox. What we heard loud and clear from our state here in Ohio was that we could not use COVID dollars to respond to mpox. We could only use COVID dollars to respond to COVID. So we were fortunate here in Columbus that we had some wiggle room in our general fund dollars that we could adequately respond to this mpox outbreak using general fund dollars. But it was very unfortunate that it took several weeks for our state and the federal government to say, okay, you can use some of your COVID dollars. That slowed us down initially because we were limited on what staff we could use for these vaccine clinics, for case investigations, but eventually it caught up. But it took a good 3 to 4 weeks before we were able to go full force ahead with the work we needed to do by having vaccine events, pop-up clinics, community outreach, to do a public campaign, a communications campaign, which you can see here. So it was challenging. We did the best we could with the resources we had. But that's a real life example of how the same type of work is being done for two different diseases, but yet you can't cross the resources, the financial resources, to make them work together. I'll go ahead and take the next slide. Another real life example of what worked here in Columbus is our measles outbreak. We had a measles outbreak that started in the late fall of 2022. We obviously don't have a budget for measles. We give lots of measles vaccines, but this was a large outbreak. It was actually the largest outbreak in the United States in 2022. We had a total of 85 confirmed cases, 36 hospitalizations, fortunately no deaths. And of those 85 cases here in Central Ohio, the majority of them were right here in my jurisdiction. This took a lot of work and a lot of effort to respond to this outbreak, to get vaccines in arms of individuals who were not vaccinated, and to get the message across. And again, there was no budget for this. We were using general fund dollars, and any resources we had. Just to give you some background, I'll take the next slide of the breakdown of some of these cases, just so you understand. The vast majority of these cases were male, but you can see that many were young. A vast majority were between the ages of 1 and 2 who were eligible for the vaccine but weren't vaccinated. I'll go ahead and take the next slide too. You can see the number who were not vaccinated. Of the 85 cases we had, 80 had never received a vaccine, 4 had received at least 1 dose, and then 1 we were not able to verify the vaccine status, so the assumption is they were not vaccinated. And as you saw from the previous slide, most of these kids were age eligible for the vaccine. You should get your first dose of the MMR vaccine at the age of 1. It is a 2-dose vaccine series, so you get your first dose between the ages of 12 and 14 months or 1 year of age, and the second dose between 4 and 6 years of age. So what was our public health response on the limited budget that we had? Again, lots of education and outreach to the at-risk communities. We collaborated with a lot of our partners. We brought CDC in for an EpiAid. We worked very closely with our state health department as well as our children's hospital here in town, Nationwide Children's Hospital. We were trying to make the MMR vaccine available wherever we could. Not only here at the health department, but also at trusted community locations where our community members felt comfortable attending and going to, and we had our nurses there providing not only the vaccine, but education. We also did a lot of contact tracing and case investigation. Probably sounds familiar, just like with COVID-19. We created a public dashboard, just like with COVID-19, and then we did a lot of media blitz and raising awareness. But again, initially we were told we could not use COVID-19 dollars to respond to this very large outbreak. So with that, I'm trying to give you some real world examples of what we're seeing here on the front lines at local health departments. So we do have a few recommendations that we would like everyone to consider. We want to look past COVID-19, past mpox, and think about how are we prepared for the next outbreak? And we are just one missed vaccine away from that next outbreak, or one plane flight away from that next outbreak if you're traveling overseas. We want to serve all of our residents to protect the health of our communities. We know there are some things we need to do now to prepare for the next outbreak or the next pandemic. This boom or bust cycle of funding has undermined health departments' preparedness in communities of all sizes in the United States. Stable funding is needed to strengthen public health and healthcare systems across the board with different needs in communities of different sizes. Funding should be focused on developing core public health capabilities and not specific to diseases or time limits. And then Congress must invest broadly in health, not just restricting the funding to specific diseases, so we can shift and respond as necessary. More federal funds should be provided directly to cities like my own, recognizing different needs of communities of different sizes so that we're prepared and can hit the ground running to respond without waiting. And finally, we need to support and invest in strong public health workforces. This was mentioned earlier, but it's true. Our teams are tired, they're battered. Many people are leaving public health or at retirement age, and we need to bring in this new generation that thinks differently and want different ways to be compensated than previous generations. And then with that, I think I'll take the next slide. I know we're gonna leave questions to the end, but I appreciate this time to speak to all of you and share our experiences here in Columbus with you. Thank you.
Thank you, Dr. Robertson, and especially thank you for those real world examples that you've given, from the perspective of a big city and the multitude of responses that you have often occurring at the same time. We're going to turn now to Dr. Joelle Simpson from Children's National. Dr. Simpson, let me turn it to you.
Thank you for having me, and what an awesome landscape that was set by Dr. Roberts. I'm going to jump right into my next slide that talks about the directions that I'd like to take this particular presentation. So next slide. I want to talk about the landscape of pediatric emergency care in the US as it pertains to the recent pandemic. Also to talk about the pediatric surge and disaster management and some lessons learned and recommendations for the future. Next slide. So just to set the landscape, we know that children comprise about 25% of the US population, What's really important here is that children often exist within the context of families. They are our children and our grandchildren. 30 million children seek emergency care every year. The majority of those not in a pediatric health system like mine, but rather in general emergency departments that may individually see less children per day than I would at a children's hospital. And I'll explain why that is particularly important when we managed the surge. There have been persistent disparities in access to and quality of pediatric emergency care. And then historically, a focus on adults in emergency and disaster planning, which was certainly unveiled, particularly during our response for the COVID pandemic and other crises. The National Pediatric Readiness Project was a survey issued by the Emergency Medical Services for Children's program initially in 2013 that found that 50%, less than 50% of hospitals, and there was a greater than 80% catchment of hospitals surveyed across the US, less than 50% included pediatric specific needs in disaster plans. COVID-19, as I mentioned, exposed and exacerbated those gaps. And when you see the graph there that shows what we will specifically talk about that has been phrased the triple-demic, which is the surge of respiratory viruses affecting children during the COVID pandemic, we see how that exacerbates the strain on our infrastructure when we were essentially not pediatric ready, as we say. Next slide. So RSV, influenza, COVID, and others contributed to this so-called triple-demic. However, I really want to be sure to highlight in that narrative that it was not the constellation of viruses that was concerning us as pediatricians, but rather the lack of capacity and capability to really care for children at that time. What we saw was that there was decreased children's hospital capacity post-COVID. Many pediatric beds across our nation had been shifted to meet the needs during COVID for non-pediatric patients. We had significant staffing limitations, significant staff sick call-outs, and certainly we've talked about the mental health crisis that has been unveiled to a greater extent during the pandemic than it had been before. In addition, as I spoke about the fact that majority of children seeking emergency care actually seek them outside of children's hospitals, and that is purely for access issues. For the majority, they're just, quite frankly, insufficient children's hospitals to meet the needs for the zip codes that all our children's all our children exist in. So it makes sense that if there is an emergency room banner, that any parent or any family member can take their child and feel reassured that they can care for those children. But what we found is that a lot of pediatric services were sacrificed during COVID. There had been, as I mentioned, decreased availability of beds, and certainly pediatric subspecialists for children that has been on a downward trend for many years. Limitations in pediatric equipment, and that pertains to the various sizes. I know, for instance, in our institution, there was a concern about the shortage of small pediatric face masks, which is critical to administering a lot of the respiratory medications needed during a respiratory crisis, such as this. Limited pediatric nursing, no inpatient pediatric beds, and critical care beds created tremendous anxiety among our families, and certainly among those of us that were trying to meet the demands of caring for our children. Next slide. We did try a few responses, and certainly I'm proud of the American Academy of Pediatrics' efforts to provide guidance on how we reduce the crowding in emergency departments and think about some solutions in a more systemic way. I urge you to search for this policy report and technical report that was issued by the American Academy of Pediatrics that not just highlights the issues, but offered some solutions. Next slide. And to talk about some of the narrative that emerged during the pandemic, we realized that there was a critical need for evidence-based guidance of the care of children in non-pediatric settings. Now, I'm proud of the evidence we've issued for those of us that are able to provide service in a children's hospital. But when the majority of the kids are being seen outside of our institutions, it's important that the evidence guides us in how we care for them in those settings. The image on the right is actually a screenshot of the American College of Emergency Physicians that did an awesome job in doing a webinar around how do our general emergency medicine population take care of children in those settings when they're not resourced the way that a children's hospital might be. We needed those responses to be rapid. We needed the dissemination of that guidance to be broad. And we needed to think about proactively the mitigation strategies needed to mitigate the shortages of medications and supplies that emerged during the pandemic. And everything as simple as liquid Tylenol that was in critical shortage during the pandemic and was certainly needed to treat our children. Next slide. Other responses that came about that we should learn from is a nationally, there was a coordinated pediatric focused town halls for us to talk about what was going on in real time with our federal partners as it pertained to each HHS region. Dr. Roberts is correct in that the uniqueness of each region is not to be understated. What happens in Washington, D.C. is different than Ohio, is different than California. And it is important for that regional approach to be voiced between our federal partners and our local communities to better reach solutions. Regionally, we started to work, and I know particularly in our D.C., Maryland, Virginia area, we talked about a pediatric bed triage system among our various health systems to be coordinated in order to best triage the patients that would need to be seen in a pediatric system and how many could be managed in outlying facilities. We had to come up with just-in-time sort of protocols for contingency care. And by that, I mean the realities of managing children in environments that are not typical, such as the hallways, creative use of outpatient facilities in order to care for children that may not have been sick enough to get to our children's hospitals, but still needed care. There was just-in-time communications, dashboards, as Dr. Roberts discussed, tracking tools, and certainly this plight of the left without being seen, which has been growing in number on average across emergency departments across the country and is in itself concerning. Next slide. Some of the federal responses that I think is important and critical for us to continue to support include the following. The HRSA-funded Emergency Medical Services for Children's Innovation Improvement Center has certainly tackled this issue. They are the issuers of the pediatric project that I talked about that surveyed hospitals across the country in terms of their readiness for kids. The icon at the top there also talks about their pre-hospital pediatric readiness project that is being issued to better question not just what happens in our emergency departments and hospitals, but also what happens before even arrival to those systems. How can we better serve kids from the minute they leave their homes all the way through the healthcare system? The domains covered by the Emergency Medical Services Children's Best sort of talk about the priority areas that we need in order to find solutions as we respond to pandemics and other threats. Next slide. I'm particularly proud of the Assistant Secretary for Preparedness and Response and the leadership in funding 3 pediatric disaster centers of excellence. And I'll show you a map of how the regional distribution of these centers really helps us talk about the different approaches we take across the country to serve our unique communities. The Gulf 7, the Western Regional Alliance for Pediatric Emergency Management, Region 5 for Kids, collaborate with the 3rd resource that has been funded federally, the HRSA Pediatric Pandemic Network, which is described on the next slide. This particular funded network is one I'm proud of as principal investigator. But here it outlines the 10 children's hospitals that are coming together in this network to learn from the lessons that we have, that we frankly learned from during the pandemic, and also to think about the other layers as addressed in the report around health equity and disparities, the urgent need to have community engaged directives in how we respond to the pandemic and other disaster threats, and also how to build the evidence in real time, as well as shared data resources across our systems that serve kids to better support our facilities that don't serve as many children on a day-to-day basis. The resources that we provide from the Pediatric Pandemic Network can be found at that website, at www.pedspandemicnetwork.org. Next slide. This is a landscape of those multiple resources, the Emergency Medical Services for Children's program, the 3 ASPR-funded Centers of Excellence, as well as the Pediatric Pandemic Network. This is an impressive landscape that we cover many states, but there's certainly some areas there that could do with some additional resources as well for us to be able to tell better the narrative of what we need to do to step up in caring for children in disasters and threats. Next slide. Most urgently as well, in addition to ongoing funding for those resources I mentioned, is also where do we go to for real-time advice in crisis and also afterwards in terms of the lessons learned and how we respond to future threats. The National Advisory Committee on Children and Disasters was initially commissioned in 2019. And I cannot say urgently enough on behalf of children's hospitals, the American Academy of Pediatrics, and for me as an individual pediatrician trying to do better for our children, it is urgent that we reauthorize this committee. The recent guidance that is shown here in the screenshot, the January 18, 2023 report from the NACCD, talks about some other underlying issues that are critical, and I don't have the time to sufficiently touch on here, but the children's disaster mental health challenges that have been unveiled, particularly so during this pandemic, key lessons that we've learned from the COVID-19 pandemic, and how do we use those as action items moving forward? And then how do we continue to respond to that health care surge during respiratory infectious diseases that happen, quite frankly, every year. But when our infrastructure is that much more weakened and threatened after the pandemic that we've recently faced, it becomes a greater threat each time these respiratory surge viruses emerge. And so I am concerned about this next winter and how we best respond to the needs of our children moving forward. Next slide. So here are our recommendations. We do need to coordinate our national data sources and include children in that narrative. We need financial and legal protections for hospitals to create flexibility where it did not previously exist. And this is outlined also in the Trust for America's Health report. We need to reestablish and expand our pediatric capacity in our communities. By that, the tools we've used to centralize patient coordination across facilities, and also supporting our telemedicine tools to better serve our communities. And last but certainly not least, we do need to reauthorize our National Advisory Committee on Children and Disasters. And with that, I thank you and await your questions.
Thank you very much, Dr. Simpson. Really excellent information, and hearing in particular something that was also articulated by Dr. Roberts is this important emphasis on infrastructure, right? And both in the public health system as well as the healthcare system, the importance of infrastructure, capacity, and the workforce, and that it's not at the time of an emergency that we begin to think about that infrastructure. So we'll certainly dive into those areas in our question and answer period. It is now my pleasure to turn it over to Mr. Andrew Pickett from the Pennsylvania Department of Health. And to our audience, just a reminder, please do submit your questions to our panel using the Q&A feature. Director Pickett, let me turn it over to you. Welcome.
Well, thank you very much, and it's great to be here. As the third presenter, I have the opportunity to build upon the work that Dr. Roberts and Dr. Simpson have already shared, so I will try to move through this and leave lots of time for question and answers. So if we can go to the next slide. Within public health, we have a diverse mission set, and we have to put our Pennsylvania Department of Health mission here. But I think it's important to emphasize what really preparedness is all about, and it is making sure that we can do all of those things that are part of our core public health mission, no matter the circumstances. And I think that is where we try to build as much capacity, even given the challenges that have already been brought up and will be continued to brought up in the conversation. Next slide. Just a bit of background about the role of Pennsylvania and really what state public health is. We do have a very diverse population, and many state health departments have the challenges that come with a diverse population, from major urban centers of Philadelphia's metro area of 4.2 million to some communities and counties with less than 10,000 residents, diverse economic, socioeconomic levels across the Commonwealth. And with that, the politics of public health also play a factor. Next slide. Specifically within Pennsylvania, and many states have similar challenges, we are both a health department in our own right, but we are also have a role in supporting our local partners within emergency preparedness activities. So for an example, within the Commonwealth of Pennsylvania, we have our state health department, and we have 11 local health jurisdictions. We call them collectively our county municipal health departments, but we have 7 counties and 4 municipalities. But that leaves the remaining 60 counties across the Commonwealth where our agency is the local health jurisdiction. So we have to play multiple roles within the public health space. State emergency preparedness also has a responsibility in the healthcare preparedness side through the federal healthcare preparedness program funding and our 6 healthcare coalitions. So, it is a diverse role that we have to manage at the state level that touches on multiple facets of preparedness. We can go to our next slide. In addition to our working up and down between federal partners and local partners, federal partners who really provide the guidance and funding, and the funding has been a big topic of conversation today, we also have the responsibility of working across within our own organization and across other state agencies that have roles within emergency preparedness and response missions. They are not traditional public health partners, but they touch upon aspects of public health. For example, our Department of Human Services in the Commonwealth is the state lead for mental health support. And so we are lock sync with them in regards to those aspects of preparedness. And emergency management is another partner that is key when we do have public health emergencies. So the role of state public health, it means reaching out and touching a diverse set of partners and being able to build those relationships. If we can go to the next slide. And I think this is where I'm going to spend most of the time in the conversation talking about many of the responses. So this is within the last 12 months, all of the different things that we have had to deal with in the Commonwealth and our local partners. At a state level, COVID-19, the MPOX. Dr. Roberts did a great presentation on the impacts of MPOX within Columbus, and certainly they were no different here immediately to her east in Pennsylvania. But the train derailment, we often think about the public health threats, biological, bioterrorism, communicable disease outbreaks, but there are certainly a much wider set of threats that public health must be prepared for. And the train derailment in East Palestine, Ohio, was not within Pennsylvania's jurisdiction, but it occurred only 842 feet from the Pennsylvania border, and as such, the impacts were tremendous on our side of the fence as well. And our preparedness program in the Commonwealth allowed us to have the good relationships we needed with our environmental health partners, with our emergency management partners, and with local communities to come in and support them. And our preparedness program was able to stand up a health resource center in the community that served over 500 residents in about 3 weeks, providing for general information needs, providing for behavioral health needs, physical health needs, and allowing them to share their stories and information and concerns with state and local government partners. Again, as the State Department of Health, we also have to support our healthcare facilities. Every year we have a number of infrastructure issues, often utilities, but we've also had staffing shortages that were quite pronounced during the COVID pandemic. Our local partners also require us to come in and step in, whether that's providing guidance or support, information, as well as funding. And they have had many of the same challenges that we have at the state level. Next slide. We've already gotten a great overview of the TFAH report. We can go on to the next slide, please. And certainly there are other ways that public health at a state and local level assesses our capability and capacity. But really what's important is what those tell us. So let's go to the next slide. So what does the Ready or Not report tell us? Fortunately, this gives us a good cross-section at a high level of what is the state, not just of public health preparedness, but that public health, healthcare, preparedness at a policy level. And there is certainly more work that needs to be done to bring these different groups together: public health, behavioral health, healthcare, community services agencies. Often we exist in silos of excellence, where we are doing great work within our own right, but how are we breaking down the barriers between us? There are also a number of issues that the Ready or Not report brings up that do require high-level legislative consideration to help us work through those. We can go to the next slide. The reports also tell us at an operational level, there is still work to be done and still more that needs to be invested in preparedness. and being able to operationalize our preparedness capabilities to become a response capability sometimes can be difficult. Next slide. So we'll get to recommendations from my perspective, and funding has been brought up from both the local public health and the healthcare level, but I will reiterate it from a state level and emphasize that it must be built on a strong basis of operational capability. Many of our partners within the public health space, within the healthcare space, significantly even in our EMS space, barely have the funding and resources to keep the lights on and the doors open. And so when that is the level of, the baseline that we are working from, additional preparedness becomes very, very difficult. And so building broad-based funding to support the day-to-day infrastructure of healthcare and public health is the only way to build that framework that preparedness can add on to. Certainly, we will still need targeted and sustainable preparedness funding. The FEP program and the HPP program are essential to building that capability and capacity. But that flexible and timely response funding is also key. And we've recognized that by the time federal government gets funding to state and local public health, the aspects that funding has been earmarked for are no longer the concerns that we are addressing. And I know Dr. Roberts talked about the discord between COVID and MPOX, and even within the COVID response. As that 3-year response elongated, the funding that we had for the beginning was not the funding we needed at the end. And if we can go to the last slide. State preparedness programs can and should continue to be the conveners and collaborators with all of these partners. And I would encourage federal partners who are on this call or listening to this, recognize that we are an opportunity to be a sounding board and to provide input into the federal plans and procedures, especially around medical countermeasures, around preparedness strategies. We are doing a lot of work coming out of this COVID, but we need to make sure that no single entity on this chart is making those decisions or plans in a silo, and that we are all collaborating to develop the best plans possible. So I will stop here and hand it back to Dr. Gracia.
Thank you very much, Director Pickett. Again, an excellent presentation and really emphasizing the operational capabilities. And so to our audience, you've heard this from the state level, from the local level of a big city health department, to our healthcare systems, just how critical this is to have this capacity in non-emergency times, as well as the ability to surge during emergency times. So this concludes our panelist presentations. We're now going to open it up for Q&A, and a reminder to keep submitting your questions in the Q&A box, and we will answer as many questions as possible. I'm now pleased to be joined by my colleague, Dara Lieberman, who is the Director of Government Relations at Trust for America's Health. She's going to help us moderate the Q&A. Dara, let me turn it over to you.
Thank you, Dr. Gracia, and thank you to our speakers for the excellent presentations. I just wanted to verbally answer a question that we've been getting in the chat. Yes, the recording as well as the resources shared today will be posted on TIFA's website in the coming days. So we'll be sure to send that out to everyone who registered. So first, this is a question that I think nearly any of our panelists could answer, although it was directed to Dr. Roberts. Among the barriers you mentioned, administrative, regulatory, political, to spending money in a smart, timely fashion, what changes do we need to make as a public health system to overcome those barriers?
Well, thanks for the question. Well, as a public health system, we have to be nimble and flexible. And, I think not every health department has that capacity to do it. I'm a large health department. I've got over 500 employees. So I've got some wiggle room. I can move someone from one program to another to respond. But smaller health departments don't have some of that same flexibility. And so, we tell our staff when we hire them that in the event of emergency, you might be asked to do other things. And we prepare them for that. We do drills. We make sure that people are aware of that and understand what that entails. And so that's something we can do on our end, but that still does not help us with the response if we need financial resources. We might have the people power, but we still need some financial resources. And for those health departments who don't have the people power to do it, they need some flexibility, whether that's hiring nurses through an agency, which our state did, and that helped all of us across the state throughout the pandemic, that they had agency nurses who could help us do vaccines, help us with case investigation. So that's something that the state health department can help provide to local health departments as well. But just preparing your staff to be flexible, being a physician leader, I think I come with a perspective of the clinical perspective, like Dr. Simpson in an ER, that you have to be able to respond to all hazards and you have to be flexible because you never know what's going to come in the door.
And a similar question for Director Pickett, but in terms of those challenges that Dr. Roberts was discussing, and you both discussed sort of the boom and bust cycle of public health, can you talk about the challenges that a department may face with underfunding over multiple years followed by short-term funding? How does that challenge your workforce or the overall response for an emergency?
Certainly the additional response funding is always helpful, but when that additional response funding is placed upon an organization that already has been suffering or a system that has been suffering from chronic underfunding, the management of that response funding needs personnel, administrative personnel, grants management folks, contracting and procurement folks to help move that money through in an effective way to help address the response. And so when you're placing that burden of significant quantities of additional funding on an already overtaxed administrative workforce, we have, certainly at our agency run into challenges with that. And, you can certainly use that money to hire more, to bring in contract staff, but there is always that drop in productivity after onboarding someone as you bring folks up to speed and indoctrinate them into the policies and procedures of an organization. So, without that baseline capacity that has to exist from day one, there are challenges no matter how much response funding we get.
Thank you. And for Dr. Simpson, in particular, this question was about hospitals that serve under-resourced communities. What can they learn from your experiences in Washington?
Well, one of the big takeaways I had from responding to the pandemic and the ongoing threats has just really been partnership. And I think that the healthcare coalition in my region has been pretty powerful in order for the conversations to happen, not just across health systems, but I see a question about the other areas that children and families exist. So it's not just the children, but I mean, there's a whole school nurse movement that took place in order to better deliver vaccines and be able to assess kids in the school system as they re-entered. And then certainly the administrators of school systems that reached out, at least in my region, to those of us in the healthcare system to better navigate all the nuances of bringing the children back in and communicating with them and educating. So I think about, the support financially and otherwise, breaking down the barriers in order to facilitate those partnerships in an efficient sort of non-free time after work type of structure would be tremendously welcomed moving forward in a more coordinated fashion.
Thank you so much. And this is a question for any of our panelists, but can you talk about how the underlying health of a community, such as the rates of chronic disease, impact the response and recovery from a public health emergency?
I'll respond. Others might be able to have a better response, but I just want to piggyback on something Dr. Simpson mentioned about partnerships. We could not have responded to the pandemic here in Columbus the way we did without our partnerships, particularly with our hospitals. And a perfect example, when you think about underserved communities, you all remember when testing was very limited across our country. And if you had a healthcare provider and you had a phone number you could call for your healthcare provider, you could probably get those tests done. But if you didn't have a healthcare provider, then it was very challenging. And those were some of the same residents who were working on the front lines who could be exposing other people. And so early on in the pandemic, we partnered with our hospital systems to provide testing to our community free of charge, no matter if you had a healthcare provider or not. And our community greatly appreciated that. And I know as a local health department, we would have never been able to do that on our own. We don't have a lab. So that would have been impossible for us to do. But with the assistance of our healthcare partners, our hospital partners, we were able to make that service available to all of our residents. And so when you think about some of the underlying health conditions of our community, one of those are uninsured, underinsured, and those individuals who are not connected to healthcare. And now in the world of electronic health records and everything's electronic, that was a challenge too for some of our residents, as they would get tested, but they didn't have email access. And so how did they get their test results? And so we had to assist them with that as well.
Oh, I thought Dr. Simpson was going to speak up. Okay.
Yeah, no, I was. I actually,
Okay, go ahead.
I had so much to say because I mean, Dr. Roberts hit the nail on the head. I was that healthcare system that got a call and said, we have to vaccinate kids because, you know, first of all, many people weren't comfortable with vaccinating 3 and under. And so when the vaccine became eligible for those populations, we had to step up and move into the communities to provide that, not just in our healthcare system. The other thing I think we observed is there's also the threat and challenge of misinformation and mistrust of our public health officials and our healthcare system in general. And I think that likely contributed to the fact that when we put forth our drive-through walk-up system for testing, it took about 6 weeks before some of our populations where we saw the greatest disparities showed up to access those resources. So I think, you know, what we've been told was a narrative that testing sites were showing up and people weren't using them. They weren't sure what information was being collected and so forth. But certainly we need tried and true and longevity in the funding and support of those systems as they exist with our healthcare partners in order to really serve our communities.
Thank you. And I think just final question, we got a couple questions for Director Pickett about environmental health, and you touched on this with the train derailment, but can you talk about the role of the environmental health workforce in emergencies and responses?
Certainly. And, you know, environmental health is one of the more challenging aspects of emergency preparedness, certainly from my perspective, you know, because, you know, it is such a broad topic. What does environmental health mean to you? You know, at the state level, we have 3 different agencies that have a role in environmental health. We have our State Department of Health, which is a small but very robust, very mighty team within our Bureau of Epidemiology that does the human aspects of environmental health. We have an entire agency, Department of Environmental Protection. And so, you know, it just increases the need for that collaboration and that coordination between different partners when you have something as broad as environmental health. And certainly, I think that the future threats that public health face are going to be environmentally based. You know, issues of climate change and health impacts of climate change are not lost on anyone here. And so, you know, building those relationships, not just within the FEP program, but across these broader spheres of influence who can work together to address these challenges is going to be important.
Great. Thank you, Dar, for sharing those audience questions with all of our panelists, and to our audience. I hope you have truly gleaned some of the experts' recommendations and experience that each of our speakers have shared. Far too many to recite, but certainly issues around the funding limitations and the importance of, yes, where we have funding going for specific health issues, but also the importance of having flexible, sustained, increased, flexible funding to really meet these core capabilities, both in healthcare and public health, the importance of partnerships, the importance of working across all levels of the system, federal, state, local, tribal, territorial, how critically important that is. You heard real world examples of what some of these challenges are, but also the opportunities. as well as the power of public health and the healthcare system to promote and protect health and well-being. And so trying to move away from this boom and bust cycle of funding to assuring that we're truly investing in prevention and public health and our broader health ecosystem to be able to meet the rising rates and severity of health threats that are occurring in communities all across the country. So in closing, I would like to thank our panelists, Dr. Roberts, Dr. Simpson, Director Pickett, for just your excellent presentations, recommendations, and responses to our audience questions. Many thanks to the staff at Trust for America's Health, to AI Media, who's provided live captioning services, and to each of you in our audience for joining us this afternoon. This is clearly an important issue that we will continue to keep at the forefront as we speak about the importance of modernizing public health, strengthening the public health system, and ensuring that we improve our nation's health security. A recording of this congressional briefing and webinar will be available along with the slides and additional resources on our website at tfa.org in the coming days. So we encourage you to stay tuned, and we will also share those resources in the near future. Thank you again for joining us. Take care and stay well.